Thank you. Thank you. Thank you, Dr. Rios-san. It's really a pleasure to be here today. I have to first of all congratulate the group, the leaders that actually put this together. My name is there, but I did very minimal. I have to be very honest, so I really have to congratulate Dr. Rios, Dr. Travis, and also Dr. Karen Liu, and some of the others that are here that have put this together. And I have to tell you that the second group of people that I would love to congratulate is you, because most people are still on the beach, as you know. So you being here, it's really amazing. It tells us a lot about your commitment for learning, your commitment to advancing your career in whichever area you choose to do that, okay? And I think what you've been seeing the last 3 days, correct? 3 days, have been, you started with the basic molecular animal models, and now I'm going to move this to the clinic. So hopefully we can integrate some of the topics that you discussed to the clinical scenario. And I am a gastroenterologist, so I do endoscopies, and you're going to see some of the endoscopies of patients that have genomic diseases that maybe some of them you already talked about before. After me, Dr. Russell, who's right there, he will be presenting, Dr. Russell will be presenting the pathological aspect. So a few pathology slides, maybe 2, but I'm going to defer that to the expert, just so that you know. Okay, so no financial disclosures, and this applies for today and tomorrow. And this is what we want to learn in the next hour or so. First, I want to go a little bit over the epidemiology of gastrointestinal cancers in Puerto Rico. Then I want to talk specifically about the forms that we know at this point that are known as the hereditary GI cancer syndromes. Okay, these are syndromes that we know what is the germline mutation that causes the phenotype. So when the patient comes to see a physician or a physician scientist, they have something in their history that makes you think about a germline predisposition, and we'll talk about that. Then I want to talk about some surveillance strategies in these individuals where we can intervene and change the course of disease. So the intervention is the part that I want to talk about, and how can we do it to make it better. And then finally, and I know tomorrow you're going to have a full morning with genetic testing. I just have like a few slides to put this together with the commercially available genetic testing, and how do we work with that. But tomorrow we have a geneticist, if I'm not mistaken, in the morning. Then we have 2 of them, I think. So you will cover that tomorrow very well. All right, so I love to move around, so let's see. So this comes from Puerto Rico, okay? This is the top 10 mortality cancer sites in Puerto Rico. And you can see on the left side, males, and then the women. And you can see that the second most common cause of cancer death in Puerto Rico is what? Is what? Colon and rectum, thank you. So colon rectum, some people call this colorectal, and some people say colon, and some people say rectum. But colorectum, it's any abnormality in the last 5 feet of bowel that we have. The last 5 feet of bowel, okay? That's called the large bowel or the colon. The last about 20 centimeters or about 8 inches, it's called the rectum. So when the cancer or the polyp is located in the last part of the bowel, it's called rectal cancer, okay? So that's why we say colorectal. Then you can see that there are some other GI cancers, like stomach cancer there, and then you can also see the liver and intrahepatic, intrabiliary, right? In women, the most common one is breast. I don't think there's a single woman in Puerto Rico that doesn't know that, right? We all wear the pink ribbons, which is extremely important. But when you ask people around, especially women, if they think that they are at risk of developing colorectal cancer, what will be the most common answer? No, that's for men. And if you ask men, they will say, oh, that's not for us, we get prostate, right? It's true, you'll see it, and it's over and over. So look at that, so it's the second most common cause of cancer death among women. When you look about, the sites, and this is again mortality, you can see the numbers. I'm sorry. Yeah, I'm gonna go to the next one. Okay, so let's look at this map. I love these maps. They actually take into account the number of individuals that live in any of the municipalities, and they calculate based on the incidence how many cases are diagnosed every year. In this case, this graph takes a period of 4 years from 2000 to 2006. And you can see that there is a gradient of color. The deeper green colors are those cases that have, those municipalities that have a higher incidence ratio, okay? So what, do we see a pattern here? Yes. Yes, we see a pattern, right? So there are certain areas, okay, so let me see, who lives in Manatí? Anybody from Manatí? Family Manatí? No, okay. Let's see, Isabela? Aha, oh yeah, true, good. Okay, so look at where you're coming from and look at the risk of having colorectal cancer. Of course, it could be that we're seeing these differences because maybe there are not enough GI doctors in the center of the island. Or maybe the diet is different. Or maybe the genomic composition of those individuals are different, right? You know that there are certain places in Puerto Rico that people are darker, right? We have the people that are African, right? Almost African. And then you get all these people that are very white with, you know, green eyes that they look like from somewhere else. And then everybody else like us, right? So, right, because I don't belong, I don't think. Anyway, so it could be that our genomic admixture, where our genes are coming from, has something to do with the way that we react to the environment. Or it could be, and I'll take in a second, it could be that maybe it's the diet what makes a difference. Yes, you had a question.
Can it be also that in the center of the island there are not many, it's not as much populated than in the north and in the south?
Well, that's a good question, but remember I mentioned to you that this is calculated based on the density area. So they take into account the number of individuals that live in that place. If they didn't, you're absolutely right. If they were taking absolute numbers, but this is a ratio. Very good point. But it could be that maybe people don't go there to get diagnosis. So that could be too, right? Okay. So this is data that we presented last year and published recently that talks about the 5-year colorectal cancer stage specific survival in Puerto Rico. So we have 3 groups of lines, the ones on the top, the ones in the middle, and the ones on the bottom. And you can see on the y-axis, you get from 0 to 1. This is the number of people that are alive, have diagnosis, right? So that's on the top. Here, this is everybody's alive, a diagnosis. And then we are following these patients for 5 years. You can see it there, or 60 months. And you can see, if you look at the legend here, that when you diagnose colorectal cancer at an advanced stage, the prognosis, the 5-year survival, it's much smaller, right? That if you diagnose someone with colorectal cancer at an earlier stage. So you can look at it here, right? The top 2 lines versus the last 2 lines. So what tells you about us and our interventions? That if we diagnose early, when the cancer is at a very early stage, the possibility of us stopping the disease, right, and preventing mortality is much better. So that's why I want to focus on prevention, and we'll talk about that for patients that have genomic predisposition for cancer. So this is what we know at this point, right? This is for somatic, the regular sporadic colorectal cancer. These are the 3 main pathways that are known: chromosomal instability, microsatellite instability, and epigenetic pathway or methylation. And I think you've discussed a bit about chromosomal instability. I don't know how much of epigenetics have been discussed here or not. Not too much, okay, but for sure this one. And today, my friend and I are going to be talking about microsatellite instability pathway, among one of the pathways. These are pathways that occur in colorectal cancer that is sporadic, okay? However, some of the patients that we know the mutations that they have will follow actually some of these pathways. So we're gonna discuss today the germline mutation that goes through this chromosomal instability pathway that is called familial adenomatous polyposis. We're going to talk about the germline mutation that uses this pathway, microsatellite instability pathway. That's called the Lynch syndrome. I am not going to talk about epigenetics in this presentation, okay? So you talk about this, right? So we are born with 2 genes, right? How many genes do we have? I'm sure that you talked about that already. About 20 something thousand, right? And how many of those genes actually work? Meaning, do we know that they actually produce a protein? Like how many? Depends where you read it, right? But not every gene that we have will actually, we don't know the protein and we don't know the function of that gene. In fact, there are genes that even though they are fine, one of those copies doesn't work, and that's called imprinting. And we have about 800 of those genes that, they are fine, the DNA sequence is normal, yet they don't work. It doesn't work, okay? Because they're methylated. But what I want to talk today about is just a regular gene that actually it's supposed to be working both copies of the gene. So normally you inherit 2 copies of the gene. You get 1 copy that gets damaged through either methylation, loss of heterozygosity, right? When the division occurs, it disappears, or a mutation or anything like that. And you end up with 1 copy that is damaged, 1 that is normal. Then a second copy is lost. Again, methylation, loss of heterozygosity, anything like that. And then you end up with a tumor. So it takes about 60 years for us to lose 2 copies of the gene, for most of the genes. So that's why the most common age when people develop colon cancer, it's in the 60s. In Puerto Rico, the median age for colorectal cancer is 67. 67. So when you have a patient that has colorectal cancer at age 20 or 30 or 50, you know that there's something wrong, because how many years does it take for us to lose the function of both copies? Many years. So it doesn't happen when you're 20. So that's immediately a red flag for thinking about hereditary predisposition. Same thing happens with other cancers, right? However, when someone is born with a predisposition, right, they are born already with one strike, germline mutation. So every single copy of that gene in every single cell will have mutated one of the copies of the gene, okay? So that tells you that all that needs to happen for us to see the phenotype is what? Lose one more. So rather than 40, 50 years, this happens in 20, 30 years. So that's why we get usually young onset cancer associated with germline mutations, okay? Because it shouldn't be that early. It's not 100% true, okay? You could have some somatic mutation that occurs very early, and I have patients with, in their 20s, very unlikely, with cancer. But most of the time when you have someone young with cancer, you're gonna think about a genetic predisposition. So these are some of the familial gastrointestinal cancer syndromes that we know as of this point. The first one, which is the Lynch syndrome, or also called hereditary non-polyposis colorectal cancer syndrome, which I'm going to talk about, but also later on, we're going to keep talking about this one. FAP, or familial adenomatous polyposis, is the other one. Hereditary diffuse gastric cancer, familial pancreatic cancer, there are multiple members with pancreatic cancer and also melanoma. Peutz-Jeghers syndrome, I'll discuss this. Leishmania, I think you talk about this a lot, right? Very good. We have a few of these patients in Puerto Rico too, and Cowden syndrome. So each and every one of these hereditary syndromes have an association with GI cancer. Either GI, meaning the lumen, esophagus, stomach, colon, or small bowel, or liver, or pancreas. That's all part of the GI tract. When we focus on colorectal cancer specifically, and you look about, the most common cause of colorectal cancer is actually sporadic. So most people that get colorectal cancer have nothing that predisposes them except their age, right? So again, what was the age for diagnosis in Puerto Rico? 67. In the US, it's about 64, 65, okay, depending on which year you fall, but the last statistics, okay? So most people that get colorectal cancer, they have no risk factor except their age, that we know of course, age, diet, smoking, et cetera, et cetera. But then there is a group of about 20% that have either someone in the family that was diagnosed with colorectal cancer, mother, father, cousin, something like that, or they have a known genetic mutation. How many, if you look at this graph, look at how small is the percentage of germline mutations. You have Lynch syndrome, 3 to 5%, FAP, less than 1%, and then some other rare syndromes, which we'll discuss today, less than 0.1%. So almost everybody, like 8 out of 10 of the people that will develop colorectal cancer will be sporadic, or at least we don't know of yet, right? Could be that there's something that we don't know yet, of course. But at this point, what I'm going to be discussing today is that small 10% or so of patients that develop colorectal cancer in the setting of hereditary predisposition. So far, so good? Good. Okay, so let's start first with the Lynch syndrome. And then let's go one by one. So all of the syndromes I'm going to discuss today, and this actually is an easy one, are going to be autosomal dominant. Okay, all of them, except one that I'm going to show you something about that syndrome, but I'm not talking too much. So every syndrome that I'm discussing here today for colorectal cancer is autosomal dominant, okay? So you will see, generations after generations. Normally about every 1 in 250 or 500 individuals will have this mutation. It's a result of a defect in one of the mismatch repair genes. Did you discuss that, the mismatch repair mechanism before? Yes. Good. So it is the mechanism that works together to correct whenever there is a mismatch, right, in the base pairs, and then it changes that, and the new template is correct. And I'll show you a graph about this in a second. this syndrome actually is quite interesting because, when you think, you're already thinking, okay, she's going to talk about colon cancer all day long, right? But I want you to pay attention to the fact that even though these patients will develop colorectal cancer most likely, because they're cancer syndromes, they might develop other cancers. And in fact, in the following conference, you're going to hear about some of the other cancers that are not colon, that are seen in individuals that have a mutation in this, in one of these mismatch repair genes. So these are cancer syndromes. So you could see endometrial, ovarian, gastric, brain, about 5, 6, 7 different cancers in these individuals. But you cannot see that. But that picture on the left side, well, actually on your right side, that's a skin tumor. And that's called a sebaceous neoplasm. And that patient came to me. Do you want it like that? Are you going to fall asleep? Just in case. For the videos, I'll turn it off. Okay, so that actually, sometimes those patients with Lynch syndrome present to see a dermatologist before they come to see an oncologist or a gastroenterologist because they present with a skin tumor. So it requires that the dermatologist knows that sebaceous neoplasms may be associated with the Lynch syndrome. And in Puerto Rico, there are a few dermatologists that are very much aware. And every now and then I get someone with the rule out of Lynch syndrome based on a skin tumor. Okay, so you have to know that to be able to put 1 and 2 together. Let's see. Okay, so here again the mismatch repair system that you already discussed, right? Each of those genes produce a protein that work together in a complex to correct the mistake when there's a mistake in the base pairs. And before we go there, those are the 5 mutations that we most commonly look for. The 2 that account for about 90% of all patients with Lynch syndrome are the 2 above, bigger letters, MSH2 and MLH1. For the skin type of Lynch syndrome, which is called MUIR, M-U-I-R, Torre, T-O-R-R-E, MUIR-Torre, it's also Lynch syndrome, but we call it like that, and because it has a skin manifestation in addition to the colon, okay? And usually, the gene that is affected in MUIR-Torre syndrome is the MSH2, okay? So it's MSH2 associated with MUIR-Torre syndrome. So again, looking at the base pair mismatch, here you can see a T and a C, which shouldn't happen. When the normal DNA repair system is working, you can see that it's corrected and that T is substituted for a G. And when the mechanism is defective, it doesn't get repaired, therefore the template, it's changed already. And that next pairs are going to be paired incorrectly. Again, the genes that I mentioned briefly. So there's something important that we need to talk about, and it's going to be discussed much more in the next conference. It's that the phenotype of the tumor is also different. So not only they have a mutation in one of those genes, which I told you the most common ones, MLH1 and MSH2, those are the 2 most common ones, but the tumor gets to look different, and this is called microcellular instability. So those errors that I mentioned to you that occur between the base pairs usually occurs in sections of the DNA that are called the microsatellites, okay? And these are sections where we have repetitive sequences, so we get like an AT, or a CG, it's long and repetitive. That's usually where we get the mistakes. So when the system is not correcting those mistakes, we will start seeing instability on those microsatellites because they're going to change. And this is measured by PCR. I think you're going to talk a little bit more about that, right, Wilson? Good. Okay, so I'm not going to drill into this. So he'll tell you more about that. And I'm going to skip this one because you're going to talk about MS right there. Okay, very good. Okay, so let's make the diagnosis. So how do I make a diagnosis, or a clinician makes a diagnosis of someone for having Lynch syndrome? So do I do a genetic testing as soon as I see someone in my clinic? No. The cost of genetic testing is extremely high. So it could be anything from $2,000 to $5,000 for evaluating several genes, right? We have to do full gene sequencing. So still at this point it's expensive. So we have to do some clinical characterization of your patients. This is called the Amsterdam criteria. So guess where they met when they had this meeting? These poor scientists in Amsterdam, correct. So they not only met once, they met twice. So they had Amsterdam criteria, that's a joke. The Amsterdam criteria 1 and Amsterdam criteria 2, but it was one meeting. So basically, this is a pedigree, and this is a 3-stage, right, or 3-family, I should say 3-line pedigree. Tomorrow they'll tell us more about the genetic testing and all that. So women are designated with a circle, and then men with a square. And then here in this particular pedigree, we're using a dot to document people that had cancer, okay? The arrow is used for the proband. The proband is the person that comes to see you. That first person that either had cancer or has a family history of cancer, and he or she wants to be informed about what to do. So I have a 51-year-old woman with cancer that came to see me. What do I have? I have that her father was diagnosed with cancer at what age? 45. And what I told you about the ages of cancer? 60 something, right? So when you get someone at age 45 with colon cancer, there could be something. And then, to make this more interesting, she also has a paternal aunt with cancer, and she also has a paternal grandmother with cancer. So the rule is very simple. It's the 3-2-1 rule. 3 individuals with cancer, at least 2 generations, 1 individual diagnosed with cancer before the age of 50. The 3-2-1. Very simple. So if you get a family that is like that, that fits the classic Amsterdam 1 criteria, if I'm talking about colon cancer, but if the family is a mixture of a family and you have someone with colon, someone with uterine, someone with brain, you know, a mixture of cancers, but they still meet the 3-2-1, it's called Amsterdam 2. How good is this clinical criteria for us to identify individuals that have genetic mutations in Lynch syndrome? It's not that good. It's about 50% good. So that means that I only get this striking pattern that anybody, you know, you don't need to know the criteria. I mean, you know that there are a lot of people, right? 4 people with cancer. That tells you there's something going on in that family. Either that or they live close to a very bad place and they're being exposed to who knows what, right? I mean, and that happens. You know, sometimes epidemiologists identify environmental exposures based on the number of cases per area. That's like the first thing that epidemiologists do, okay? But in this case, if they live in a normal place and there's no benzene or something going on, and you have 4 patients in a family, immediately you have to think that there's something wrong. And here is the classic Amsterdam criteria. And what do we do with this? So patients that satisfy or fit the Amsterdam criteria, the first thing that we do is that we go ahead and order genetic analysis. This is a little bit controversial. Some people order first a screening with a tumor analysis, and we'll talk about that a little bit later. But this is one approach. So if the resources are available, and you have a family like the one I showed you a second ago, you're going to do a germline mutation testing for the individual that has cancer. That will be the first person that you test. So you can see, we do the mutation analysis. If it comes positive in one of the, in any of the genes, then you know the mutation of the family, and then you can test anybody that is at risk. And let me put this in an example. So about a month ago, one of my families that we suspected that they could have Lynch syndrome, they are from Manatee actually. She has colon cancer, age 60, I guess, no, 59. Then that same woman had endometrial cancer like 20 years before, okay? When I look at the family history, her brother had also colon cancer. So I didn't have the classic Amsterdam, right? Because I only had her, not younger than 50, but it was her case, her brother. But she had 2 cancers. And when you have someone with 2 cancers, 2 Lynch syndrome cancer, that's good enough, and that's called a Bethesda criteria, which I'll mention in a moment. So we went ahead and did testing for her. So she has a mutation in an MSH2 gene. So now I know the mutation of the family. So then, because I know where is the mutation, which codon is the mutation, then I can go and I can test her children, and I can test her brother, and I can test her niece or nephews, and see how many of those people that are not affected yet, I mean, they don't have cancer, so I don't, haven't done anything with them, how many of them have a predisposition to develop cancer. So we went ahead and we did that, and that was just before the holidays. So we got the mutation. It was kind of very moving because she actually paid for all, for her 2 children and her 2 nieces from her brother, the tests, and that was her gift to them. So the price, so you have an idea, the price for a single site mutation analysis is about $400, more or less. Commercial, okay, so this is, CLIA certified commercial, versus the first time when you do the whole sequence that is about $3,000. So she gave this as a gift to her family, to her, children and niece. And unfortunately, one of her children, her son, and one of her nieces have the mutation. So now I have to deal with that whole aspect. And tomorrow you're going to talk about how do you deal with having someone with a genetic predisposition. Because you know that they have a higher risk. It's not that they are 100% to have the mutation, I mean the cancer, but much higher risk. So that's the way we do it. So once you have the mutation of the family, then you test the family members at risk. And then if they have the mutation, you have to start intense surveillance and prophylactic intervention as requested. The Bethesda criteria, and I'll briefly mention this, I just want you to memorize maybe two. Number one Bethesda criteria. Someone with colon cancer before the age of 50 that already satisfy the Bethesda criteria, and we can go ahead and start evaluation for Lynch syndrome. Younger than 50, that's easy, younger than 50. Some other that, might be important to also memorize, when someone has more than one cancer, like that patient that I told you about, her name is Yvonne, and Yvonne had colon and endometrial. That's not a common thing. Someone shouldn't be having 2 or 3 cancers, okay? That's the second Bethesda criteria, and this is regardless of age. Remember I told you that in her case, her colon cancer was like 59, almost 60? So regardless of age, 2 Lynch syndrome cancers will be Bethesda criteria. And some others that I'm going to leave there to have the pathologists go over that. Okay, this is again a pedigree, but this one is done with a software that is called Progeny. Not sure if you already talked about that, but tomorrow you're going to learn about Progeny. So Progeny is one of the software that we use. It's almost like, think about Access. Have you used Access? Or that's too old for you guys. My age. What else is similar to that? Epi-info, most people don't use. It's a software that helps you construct things. So it's just a software. So this software, actually, you build data fields. So you create the field, so you put names, ages, et cetera, and at the end, it shows you this, and this is called a pedigree. And again, we have how many generations? 1, 2, 3, 4 generation pedigree. And in this case, the proban, which I mentioned to you, is marked with an arrow, in this case an arrowhead. It's a woman or a man? Woman. And in this case, I wrote below here, you have that this woman had colorectal cancer at age 29 and a second one at age 49. So 2 cancers in one individual younger than 50, but even if they were older than 50, that would be considered already a high risk. And of course, this pedigree is highly penetrant. You can see multiple people with cancer, but just to show you, one of the Bethesda criteria. So if your patient has or satisfies the Bethesda criteria, which the number one, which is the easiest one, is younger than 50, right? So if someone had colon or endometrial or ovarian cancer younger than 50, then you're going to think about that, and then we will start this algorithm looking at the tumor, which is doing the analysis of the microsatellite instability, which you will learn in the next conference. But keep in mind that that will be the screening test that we will do in that tumor. You might be wondering, why are you doing a screening test in this case rather than going directly and do the germline analysis? I'll tell you why. Because the likelihood of that individual having a mismatch repair gene mutation is lower than the likelihood of an individual that satisfies the Amsterdam criteria. So if in a world of cost effectiveness, it's more cost effective to do a screening study in the tumor, look whether or not the tumor is suspicious for the syndrome, and then go ahead and do the germline analysis. But in someone that satisfied an Amsterdam criteria, and I show you that pedigree, that horrible pedigree, multiple people, 2 generations, 1 person with the cancer diagnosed before age of 50. Very good. So I keep telling you that these are syndromes, cancer syndromes. And you guys know that I'm focused on colon, but I want you to know that there are other cancers that are associated with this syndrome, Lynch syndrome. Endometrial, which will be discussed briefly, is the second most common cancer among these individuals. And sometimes women with Lynch syndrome can present with endometrial cancer first, before they actually present with colon cancer. So they could be seen by gynecologists before they actually are seen by GI doctors, okay? And if a gynecologist is not thinking about that, that's it. The woman will present 10 years later with this colon cancer because nobody even thought about that. And we see that, unfortunately. In fact, some of the things that we do is that we go and talk to these other doctors that are not GI or surgeons, like gynecologists, like dermatologists, so that they are aware of these connections between the syndrome, right, and the cancer, so that they can prevent the disease. So this is a very simple figure. This is the risk of cancer in percentage on the y-axis. Here you have the chances of having colon cancer in someone with Lynch compared to someone from the general population. So 0.3 is the chances of someone that does not have the disease to have cancer before the age of 50. Look at the number, very small. Someone with Lynch syndrome, about 25% of them will have colorectal cancer before the age of 50. And when you look at the age of 70, you can see the disparity between one and the other. Same thing is true for gynecological cancers. So in the endometrial cancer by age 50, in someone without this disorder, it's very low, less than 1%. In someone with Lynch syndrome, it's much higher. And then ovarian cancer, which is at the end, it's also very unlikely of someone to have ovarian cancer before the age of 50. So I keep telling the same thing, the age, right? Everybody's clear about the age. And we understand why. I mean, they're born with the loss of one of the copies. So they're only working on the protein that is produced by the copy that is healthy. So if by methylation that gene stops working, then already there you have this no protein. And it could happen anywhere in their body, right? Because every single cell is identical. These are germline mutations. So how do I prevent getting cancer, colon cancer in this case? We do colonoscopies. This is something that gastroenterologists and colorectal surgeons do. Look at when we start, between the ages of 20 to 25. Do you guys know when do we normally start colorectal cancer screening with colonoscopy in someone without family history? 60, a little bit younger than that. 50, right? Because I want to be able to catch the polyp before it actually becomes cancer. Since we know that cancer occurs around 67, 65, then the guidelines are that we start colorectal cancer screening with colonoscopy at age 50, if there's no family history. However, in someone with such striking family history of cancer, we start much earlier. And look at the numbers, ages 20 to 25. And then we repeat it every year until they're 40, and then we repeat it every year after that as well. We know that doing that reduces, we're able to reduce the risk of colorectal cancer by over 50% compared to individuals with Lynch that are not screened. And then the mortality is also reduced. Very briefly, I'm just going to show you this, where this data comes from. This is actually quite important. Do you guys know the type of graph that I'm presenting here? Anybody have taken epi, biostatistics? No? Kaplan, no, okay, sorry. Kaplan-Meier. This is something that it's a good idea to know. So this is the same type of graph that they present to us over and over again whenever you're looking at a disease and time to follow up. So whenever we're following up people, we use Kaplan-Meier. It's the classic curve. On the y-axis, you're going to see the proportion of individuals. Everybody at the beginning is alive. So that's why you get everybody here. You always start. Sometimes you can do it the other way around, but in this case, it's done, everybody's alive. And then as we follow up these individuals, and here you have in years, 15 years follow-up. This graph presents 15-year follow-up. And you have different cohorts, but just to make it very simple, you can see that this group, whoever they are, they have the worst survival because the line is at the bottom, right? So who are these people? These are people that had mutation that did not undergo screening colonoscopy at the same rate that the people that had mutation but underwent screening colonoscopy. So clear data. And this comes from different places, from the Finnish Hereditary Cancer Registry, the German registry, and overall 65% decrease in cancer associated with the use of colonoscopies. And let me show you now. This is actually a colonoscopy from one of my patients. This is a gentleman that came for follow-up after 3 years. And this was a patient with Lynch syndrome that got lost, for many reasons. He didn't show up until 3 years later. And you can see this large mass, and then the blue, it's a biopsy that we use to take biopsies and send to the pathology lab for diagnosis. This is a large lesion, and it occurred in a period of 3 years. Sometimes I've seen that this happens in a period of 1 year, 2 years, so very, very rapidly. So the time from, whenever they get the polyp to the point that they get cancer is very short, between 3 to 5 years. In someone without this disease, it's about 15 years. So you can see the difference, and that's why we do screening. And here, you can see that when someone develops colorectal cancer, sporadic colorectal cancer, again, no family history, sporadic, we do the colonoscopy, the follow-up colonoscopy at year 1, then 3 years later, and then every 5 years. When someone with Lynch gets cancer, we follow them very, very closely every year. And we do endoscopy, very detailed endoscopy using dyes. We call that chromoendoscopy. Tomorrow I'm going to show you some data on using chromoendoscopy to try to see those flat lesions. I've seen patients with cancer in lesions as small as 4 or 5 millimeters. It's in millimeters. So it's like looking, imagine a football field and you're finding a little dot. I mean, the colon, how many feet it has? It's huge, right? 5, 6 feet. And I'm describing a 5 millimeter lesion. Very easy to, not to pick when you're doing a colonoscopy. Here's another video, and this is actually to show you what we do during colonoscopy. This patient came for evaluation for surveillance after a cancer, and we identified this lesion. This is located in the cecum, right, the first part of the colon. You can see that we have we injected fluid and a dye underneath the lesion, and now we are basically cutting with cautery, and you can see that's called a snare. That's the cecum, and you can see the blue below, and then we go and we take a few bites until we take it out. So this is done by advanced endoscopies and also surgeons. But the colonoscopy only works if we're able to get the polyps out or get the cancer early, so that then they can do surgery and then the patient doesn't need chemotherapy. But if we did not remove this and I just look at it, then we didn't stop the adenoma carcinoma sequence. But again, this is just so that you see what we normally do. So I don't want anybody to get dizzy here. I don't know, I forget out. Sorry. I know I had one student, this was so cute, undergrad, I think, yeah. Last year for undergrad, and she wanted to see colonoscopies in vivo. Usually the undergrads, they don't go to the endoscopy suite or the OR unless they're really risky and they want to do it. And, so this lady, she was very excited, said, fine, let's go. So we're there, I'm sitting there doing my colonoscopy, and she's behind me, and all of a sudden I hear it. That was it. No more undergrad unless they're sitting next to me and have breakfast. She had no breakfast. She got this in the whole story. But anyway, but that's the whole concept of colonoscopy and intervention. I mentioned to you guys that we use the best type of equipment to try to diagnose these lesions. I mean, the pictures that I show you, those videos are big lesions, right? Anybody could have seen that mass. But sometimes the polyps are very small, 5 millimeters, 2 millimeters, 6, tiny, tiny. So we use something that is called chromoendoscopy. And chromoendoscopy means using dyes, like indigo carmine, like methylene blue, to spray the mucosa, to improve the contrast between the normal mucosa and the abnormal tissue. And this paper here actually look at 36 patients that were Lynch syndrome mutation positive, and they were doing surveillance colonoscopy with and without chromoendoscopy. So they did a colonoscopy without dye, then they sprayed the dye and did the colonoscopy again. And then they compared the number of lesions identified with and without the chromoendoscopy. And by doing chromoendoscopy, they were able to detect an additional 45 lesions. So what I'm trying to say here is that these individuals that have this high risk of getting cancer should be seen by people that take the time, that know what they're looking for. It's not a regular patient. This is someone that will take maybe 45 minutes to do a colonoscopy versus 10 minutes of a regular colonoscopy. So, it requires that extra time, we use special lenses, etc. Plus, the most important thing is that the patient actually understands what they have and they don't get lost to follow up. So that whole genetic, behavioral part of the physician, right? It's not only looking at the cells, it's also talking to that patient and really making sure that they understand. And here are the pictures. You can see before chromoendoscopy, most of the lesions were located on the left side of the colon. After chromoendoscopy, you see all those black ones were new lesions that were seen by using this special dye. For the gynecology, screening, to prevent that, we recommend for women with Lynch syndrome, they have an endometrial biopsy and a transvaginal ultrasound starting between the ages of 20 to 25, and they repeat this every 1 to 2 years. The CA-125, but I don't know, Karen, were you talking about the CA-125? Okay, so you know the controversy, they know the controversy and all that. For this population, I think it's the only place that if I were to use it, I would use it. But not for regular screening, but this is part of the things that we do at this point for prevention of screening. So to summarize Lynch syndrome, early onset colorectal cancer, magic age 50, but it's just a magic age. You could have someone at 51, 52, 50, that's still very young, okay? Early onset of endometrial cancer, 2 or more Lynch syndrome cancers in the same individual. Remember my patient, colon cancer, but had previous history of endometrial cancer. She had the mutation, and now we're gonna deal with the family members that have the mutation and do not have the disease yet, right? The phenotype is not expressed yet, so we could prevent. All right, questions about Lynch syndrome before we move to the second group. Good? You're gonna get more answers with the next question, which, in the next presentation, which will be focused on Lynch syndrome and pathology and all that. Okay, so now let's talk about this adenomatous polyposis syndrome. So, let me see if I can lower that. So, familial adenomatous polyposis, it's one of those autosomal dominant. I told you everything was autosomal dominant here today. The incidence, 1 in 10,000, more or less, 100%, very close to 100% of developing colorectal cancer. And I lowered that, I don't think you can see it very well, but that's a colectomy specimen, and in the middle, this is a mass, right there. So this is a specimen that came from a patient that underwent surgery due to FAP. We know the mutation. The German mutation is in a gene that is called the adenomatous polyposis coli gene, or the APC gene, and it follows the chromosomal instability pathway. I told you that there were 3 main pathways that we know at this point. Chromosomal instability is the most common one. About 60 to 70% of all colon cancers go through that pathway. In this case, FAP, rather than being a somatic mutation, of course, they get a second hit, is a somatic, but the first one is germinal. So they are born with a mutation in that gene, the APC gene. Therefore, it goes through that pathway, chromosomal instability pathway. The cells will be, they'll have aneuploidy, okay, because that's the pathway that they take. And similar to that other, the first syndrome, the Lynch syndrome that I mentioned to you, that they are cancer syndromes, right? So you don't think about colon, you think about multiple cancers. With FAP, it's the same. They could have multiple cancers, and in fact, or manifestation. That there is actually a picture of a skin of a patient. Can you see those little cysts? That's the back, I think, of a patient that, on the physical exam, you could feel those little bumps. They could become very big to the point that someone could be deformed. I have one of my patients that is actually quite deformed, the neck, all because of cysts, and they could bleed on the inside and they could become infected. That's really, we call a variation of FAP that is called Gardner syndrome, when they get this all extraintestinal. So Gardner, like a gardener, Gardner syndrome. When they have these manifestations, they could have other tumors like desmoid tumors, they could have bone growth, we call those osteomas, and they could also have a change in the hyperpigmentation, in the retina? That is called congenital hypertrophy of the pigment of the retina. Okay? Let me show you a video. This is actually a 15-year-old lady that was referred to me by a pediatric GI doctor after she was having occasional bleeding. And I'm sure that anyone here can see that they're like little bumps, and I think I'm going fast, but you can see all those little bumps. Those are small polyps. So she doesn't have cancer yet, but if we don't take, you see all the polyps? But if we don't take that colon out, she will have cancer. How likely? 100% likely, because this syndrome is associated with that, that high penetrance, and this is a classic FAP. There are variations of FAP that we could talk about that later, but in the classic one. This is a colectomy specimen. Again, you can see the multiple polyps, but you saw it in vivo in the other picture. So since we said that there were not only one cancer, this is a syndrome, we talk about the other cancers in FAP. And what are the other cancers? Duodenal is one cancer that they could develop. In fact, the number one cause, and I'll get your question in a second, the number one cause of cancer death among patients with FAP is not colon cancer, because everybody's aware that they will get cancer in their colon, so they undergo, they go and have their colon removed. Total proctocolectomy. right? And they get ileoanal anastomosis. The most common cause of cancer death is duodenal cancer, because patients don't undergo endoscopic surveillance enough, upper endoscopy surveillance. So, yes, sir.
Regarding the surgery,
yes,
the colon removal, how does that work? Remove the whole colon?
Yes, yes. So remember, the whole colon, every single cell of the body of the patient that has a germline mutation will have that mutation. So if you only take half of the colon, or where you think there are more polyps, and you leave that other part has the same risk as the part that you took out. So the way it's done, they take the whole colon and they use the small bowel. This is done by colorectal surgeons. And they create like a little pouch that it's connected to the anal. So it's called an ileo, right, the small bowel, anal anastomosis. And basically nowadays they don't leave almost anything behind, because any colonic tissue that you leave there will develop polyps and may develop cancer. Okay, it's not a simple surgery. It's a two-step surgery, and it takes about 2 months for the person to get better. But that little girl that I show you, 14, 15, she underwent surgery in the summer before she went back to school, and she got the ostomy temporary. Then they reconnected her, and she's having a normal life. Now I'm going to follow her, to prevent any of the cancers. Yes.
So life is normal after?
Yes. In fact, we have patients that are, I have in our registry, we have one woman that is a physician. She works nearby, and she was able to continue her career. We have, of course, you have to monitor these things, but as long as you monitor and do surveillance, they do well. They do well. This video, it comes from the stomach. Oh, thank you. Thank you very much. Let's see. This is a stomach. So they not only get polyps in the colon, they also get polyps on the stomach. And different from the polyps in the colon, these polyps tend to be benign. So I'm sure that somebody's thinking, do you have to take the stomach out, right? No, we don't take the stomach out, okay? So these polyps, God was so good, or whoever created the whole universe, that the stomach, somehow it can live, and those polyps never get the next set of mutations to become malignant. Okay, they're benign. They're called funded gland polyps. So what do we do with these individuals? We do screening, endoscopy, in this case surveillance, right? Let me tell you something that is important. We always mix terms, I think because we speak Spanglish, right? So screening means when you don't know that someone has a disease, you're doing screening to detect disease. That's screening. But surveillance is when you know that someone already has a predisposition, or had cancer, or had whatever they had, and you're following them. That is called surveillance. So screening, the person has to be fine. If the patient is having rectal bleeding, that's not screening. That's a diagnostic procedure, because you already know that they have a disease. There's something going on. So surveillance is the term that we use to do endoscopy in patients with genetic predisposition. They don't have the cancer yet, but they have the high risk for developing cancer. Is that very clear? Screening versus surveillance. So how do we manage these patients? So we perform surveillance. Those are surveillance guidelines. For the colon and rectum, we do a sigmoidoscopy very young, starting between the ages of 10 to 15. For an attenuated version, which I didn't discuss, I'm not going to talk this, I'm going to jump to the stomach and duodenum. We do upper endoscopies starting between the ages of 25 to 30, bless you, to look for polyps in the duodenum. Okay, I told you the polyps in the stomachs are okay, but the ones in the duodenums are the ones that will become malignant, and the patient might develop cancer. Surgical guidelines, we talk a little bit about that. We take the whole colon out most of the time. There are less severe syndromes, which we might do something different, but I want you to know just the most common one. Familial adenomatous polyposis, a mutation where? Which gene? APC gene. Risk of cancer? 100%. Okay? These individuals' management? Surgery, once they get polyps in their colon. Red flags for adenomatous polyposis syndromes: 10 or more cumulative colorectal adenomas. So when you do a colonoscopy, there are more than 10. Or colorectal cancer associated already with multiple polyps. Very good. So we have covered the most common adenomatous polyposis syndrome that we know, familial adenomatous polyposis. Let's now switch gears a little bit, and we're going to talk about the hamartomatous polyposis syndrome. And I think I was daring enough to put a slide of a pathology, which if you don't mind, and you can help me, okay, All right, thank you. You know, you never, it's like reading an x-ray with the radiologist in the room. Never do that. You know, you ask the brain, I wouldn't even dare. Very good, all right. So Peutz-Jeghers. So Peutz-Jeghers syndrome, it's a disorder, again, autosomal dominant, caused by a mutation in several genes, and we'll talk about that. The most common one is the STK11, okay? And classically, this patient will be seen first by a dermatologist before they come to see a gastroenterologist. Can you see the pigments on the lips? That hyperpigmentation is classic for Peutz-Jeghers syndrome. So normally these patients will develop polyps that are called hamartomas, and we'll see that slide in a second. The most common mutation is in the STK11. The incidence is very rare, 1 in 100,000 live birth. However, these people are very unfortunate because they do have a very high risk of developing multiple cancers, including breast cancer, which is something that you don't think of, right? When you look at the colon, you're not really thinking that someone that may develop colon cancer could also develop breast cancer. But these individuals, both men and women, have a high risk of developing breast, pancreas, and some other gynecological cancers. Here, I show you this a patient of mine as well. The other figure, it's actually a young 19-year-old athlete from the center of the island of Puerto Rico. This is another gentleman, and you can see the skin right in the hands, in the feet, in the toes, and here inside, even inside the mouth, you can see it. So this is skin diagnosis of the disease. So the dermatologist can make this diagnosis. He or she doesn't need anybody else. When you have a patient like that, they make the diagnosis of Peutz-Jeghers syndrome, and then we go on to the rest. We do the germline, we do genetic counseling, germline mutation, and we do surveillance for any of the cancers that these individuals have. Okay, I'm going to give this one to you, please, Ross. What are we seeing? Okay, I'll describe this one. A polyp. That's it.
So these polyps look just like the polyps you see in FAP, but microscopically, the polyps don't have dysplasia, they don't have adenomatous changes. They're characterized by normal structures, but in abnormal locations. So you'll have, instead of the muscle wall being down here at the bottom, you get muscle going all the way up top to the mucosal surface. And these are normal glands, but they're branching, have abnormal branches, cystic dilatation, and they're kind of misplaced. So hamartomas I always think of as being normal structures, but in the abnormal locations.
Excellent. Excellent definition. I always look at them and they look like little trees, right? They have that, little tree type of feeling. But that's the classic hammer. Oh no, of course I have another one that I have to. Okay, so this is the gentleman that I showed you the lips before. This is actually an endoscopy of the stomach, so a gastroscopy. And this is actually a rather large polyp. This one was seen in the stomach, specifically in the body of the stomach. And what we're doing with this particular case, we actually just, loop it and take it out. So, and the patient did very well. These individuals, we have to, do surveillance for all of these cancers that I mentioned to you before. And I think I briefly will discuss that. Cowden syndrome, before we go into the rest, let me share a little bit about Cowden syndrome. So Cowden syndrome is also very rare. So 1 in 200,000 live birth. Okay, so not a common. Again, autosomal dominant, the penetrance is incomplete, so not everybody that has a mutation will have the same phenotype. The gene, germline mutation is known, is in the P10. It's a tumor suppressor gene, and they develop cancer in about 80% of the cases. So those are the 4 most common manifestations of these individuals. The Cowden syndrome patients, they have a higher likelihood of having breast cancer, thyroid cancer, endometrial cancer, and very interestingly, these patients, I've had, in our registry, we have 4 Cowden syndrome patients. You say, how? 4? So I told you it's 1 in 200,000. So in Puerto Rico, for every million, we should have 4 people. So we should have 16 people with Cowden in Puerto Rico, 16, and we have 4. I mean, that's huge. So either the statistics don't apply for Puerto Rico, right? Or we're getting people to actually recognize these individuals and they're being referred to the cancer clinic. I don't know which of the 2. But we have those 4 patients, and they usually get referred to us by a GI doctor that does a colonoscopy and an upper endoscopy and sees polyps that are not the classic adenomas, right? They look a little bit different, and when the pathologists review this, they describe this as hamartomatous polyps. So when you have a patient with hamartomatous polyps, you have to think that there has to be, now, you have to think about it. Patients could have 1 or 2 hamartomas and not be a syndrome, right? And you guys see that, But when you see multiple, then you have to put that together with the rest of the physical exam. And Cowden syndrome patients have a few things that are diagnosed by dermatologists again. I don't know if anybody's interested in dermatopathology or anything like that, but in this case, they present, and I'm making the next slide, I think I have that. So they have this, they look like bump on the skin, and they're called trichomelastomas, and they also have the papillomatous papules. They almost look like acne. And when you look at, you speak with them, they tell you that they have always been told that they had acne and they go to dermatologist, but nobody thinks anything. So you put that one with some other markers. I've never seen this one. This is from Google, but everything else is mine. And there's one thing that is extremely interesting about these patients. They have big heads, so microcephaly. So macro. So when you measure, and that's something that I learned at City of Hope when I took a course on genetic. I don't know about Karen, have you been involved with them or not? City of Hope. So they have a very nice curriculum. That is an online curriculum for clinical people or scientists, someone that wants to know a little bit more about genetic predisposition. And they told me that everybody carries this little tape, basically, to measuring tape that is round, very cute. So I said, my goodness, when am I going to be using that to measure my patients? 2 weeks after I came from City of Hope, I'm sitting there with this patient that I'm going to show you his video in a second, sent to me by a gastroenterologist with these hamartomatous polyps, which didn't fit the bill. Then I look at him, and as I'm looking at him, the whole thing came together. That's why you need to study, because otherwise I would have said, well, hamartomas, next page, easy. No. He had the skin, and all of a sudden I started almost jumping. I took my little thing out and I measured his head. So for a man, anything above 65, right, is high. For women, it's about 55, 58. He had 66 centimeters. 66 centimeters. So when I measured, and I went ahead and I measured everybody in the room, so that, to make sure, I even measured myself. But it's something that unless you knew that this is a phenotype, right? A series of clinical manifestations that are associated with the germline mutation, we would have never made a diagnosis, and we could have not prevented cancer, which is what we want to do here. You want to make a diagnosis and prevent cancer. And I think in this next slide, I'm going to show you from this patient that I measured his head, the duodenum, the very small, and look at this, and remember the big polyps that we had in FAP? These are much more discrete. Can you see that? They look like little fingers. There's one there. I mean, they're not as easy to see. Like there is one there. Can you see it? Those tiny, they're not as big and as florid as a patient with FAP, but nonetheless, they are hamartomas. The good thing about the hamartomas is that if they don't grow too big, they really don't have any harm, right? They usually don't transform to become malignant. Usually these patients present because of if the Peutz-Jeghers, actually, not the Cowden, but the Peutz-Jeghers usually present when the polyps become large and they obstruct the small bowel and they get an acute small bowel obstruction. That's usually the most common diagnosis, okay? Not because the tumor becomes cancer, but the tumor is big and it's inside a small bowel and it causes intussusception, which means that one loop of the bowel gets inside the other, like that. And it's very, it's difficult. Here, the same Cowden patient, and again, remember the FAP and look at the difference in the small polyps that this patient had. But the gastroenterologist thought that this was an FAP patient, referred the patient to us, and then we made the diagnosis of Cowden. Okay, so to finalize, we're gonna have just a few slides about genetic testing. Tomorrow you'll learn a lot about genetic testing with the 2 genetic counselors that will be participating. But this is actually extremely important, and this actually takes together what you learned the first few days about germline predisposition, germline mutations, and syndromes. And this should be done in the context of having the patient with someone that is trained as a genetic counselor, or at least I have to tell you, in Puerto Rico, we don't have genetic counselors. That's a disclaimer that I'm sure that you guys know that. We don't have people that are trained as genetic counselors in Puerto Rico. So people like me and some others get trained. I did it during my fellowship. So I work with genetic counselors, and I work with people that had hereditary cancer risk clinics, and then you learn about it, but it's not, I don't have a master in genetic counseling at all, right? This is a formal degree. But you do the best you can, right? So you get the certificates, and and you learn, and you try to take these courses. But in the ideal scenario, you would like to have a genetic counselor to provide this information, because telling someone that they have a mutation inherited, and the first question is by whom? Who gave me this? And in about 20% of the cases, you have a patient that have nobody in the family with the disease. So you know that they're the first. That's a de novo mutation. But once they have it, that must have happened very, very early in the embryonic development, right, at the zygote level or something like that. Unfortunately, every single cell of their body will have the mutation, and that means that the gametes will also have the mutation, so that they have there's a 50% likelihood that their kids will also inherit that. So it has a lot of behavioral parts beyond the molecular biology, which is what you've been, discussing so far. Tomorrow you'll learn more about that. How do you handle that? I told you I have to talk with this woman and tell her that one of her sons and her niece have this predisposition, and then we have to make it and change the perspective to talk about prevention. And tomorrow I'm going to talk about prevention and what are the chemopreventive trials that we normally or currently do to prevent cancer in these patients. But that's a topic for tomorrow. So very briefly, we have a society, the American Society of Clinical Oncology have guidelines for who should be tested. So personal or family history is suggestive of hereditary cancer risk. And I told you, many family members, that will be a red flag. Younger than what? 50, right? Just, again, it's a number. It could be a little bit more or less, but test needs to be adequately interpreted, and test results need to aid in diagnosis or influence medical management of the patient or the family. And I'll tell you one little thing about some other diseases. So Huntington-Chorea. Have you heard about that? That's a neurological disease. Huntington, right, disorder, correct, that is associated with, the lifetime risk of it's a horrible disease. They start losing their capacity of work, the neurological system. It's a disaster. It's a horrible disease. So we know what is the gene that causes Huntington-Chorea, but we don't have an intervention yet for those individuals. And families that have someone with that disease, they are given the option of knowing whether or not they carry this mutation. But if there's nothing you can do about it, then it becomes a really ethical question. And I think tomorrow you might hear about some of the ethical aspect of doing genetic testing. And at least for me, they feel that we're doing something because we can offer them options. Surgery, prophylactic surgery, medications, endoscopy, some sort of intervention to prevent. At least I'm sure that you guys feel the same way. But if we just diagnose someone and tell you know what, you have the gene that will cause blah 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 in 10 years, and you cannot do anything about it, that's a questionable test to do. These are the things that we talk, right? Who may benefit? People with multiple cancers, multiple family members with cancer, cancer at a young age, certain ethnic groups and racial group like the Ashkenazi Jewish people, because they have some founder mutations, and first degree relative of known mutation positive individuals. And you could have 3 results when you do a genetic testing: positive for a mutation, a genetic variant of uncertain significance, and no mutation. I'm not going to talk about this one. I'm going to let the genetic counselor tell you about this. But if you find positive mutation, you have the mutation of the family. So you can now test those at-risk family members, like we discussed previously. And you can actually have interventions to prevent disease. This actually comes from one of the companies that does this commercially. For this patient, we were testing the MLH1 and MSH2 sequencing, the 2 most common for which syndrome? Which syndrome I spoke at the beginning? Lynch syndrome, yes. So these are the 2 most common germline mutations, right? This is the mismatch repair system, MLH1 and MSH2. And you can see that the company first does sequencing, right? So they look at every single nucleotide. Then they do a rearrangement, the way that the gene is rearranged. And they do that for this 3 in this case. And you can see that for the MSH2, there was a mutation identified. And they write the interpretation is that it's a deleterious mutation. So that mutation changes the protein. Either truncates the protein or changes the behavior of the protein. And that will be a patient that has a positive mutation. So in summary, suspect familial cancer when you have young individuals with cancer, individuals with more than one cancer, and those multiple family members. Consider genetic counseling and testing, which tomorrow we'll have a full morning on that. And then establish an appropriate and individualized medical and surgical plan. And that is the key, the intervention. Whenever we can take that knowledge that comes from the laboratory and then use it right to take care of our patients and hopefully prevent cancer. And I think that's what I have at this point. Yep, that's all I have. Questions for me before we turn it.